third session of the Weekly Huddle, and I welcome all of you for today's discussion. My name is Anoop, and joining me today is my friend and co-host Praneeth. Praneeth is a little bit occupied with some personal work, so while he is online, we'll try to see if he can participate in any of the discussion or not. There may be some background noise with him. Today, we are talking about stroke in atrial fibrillation, and I chose a case which definitely deserves a multidisciplinary discussion. I was hoping to get a little bit more representation in today's discussion, but at least we'll get started with the current audience that I have. Today's discussion, I will be joined by, or I am joined by Dr. Haigiry, who is an electrophysiologist, and Dr. Rukmini, who is a neurologist. And I'm hoping to get a couple of more guests as we continue our discussion. So the case that I have brought in today, this is not a very common scenario, but it happens once a while. And I brought this case so that we can initiate a little bit of discussion and increase our understanding on how we deal with these entities. So it's a 74-year-old female, and in fact, as I brief this case, I will initially hand over the discussion to Dr. Rukmini because I want to get the neurology perspective on these cases before I move on to cardiology aspect of discussion. So it's a 74-year-old female. She has a history of diabetes and hypertension. She has permanent atrial fibrillation for which she is taking digoxin, and she's on anticoagulation using a novel oral anticoagulant, namely Rivaroxaban 20 milligrams in this particular setup. She is on routine medications for diabetes and hypertension, which I'm not listing for maintaining the relevance of today's discussion. So all of this chronic treatment was being done with a different doctor. We actually got in touch with her when she was admitted with us. She presented with a subsegmental infarct involving left middle cerebral artery. And it was a non-disabling infarct. So when she was admitted, she had some few deficits. She was admitted under neurology and was managed accordingly. She did not have any hemorrhagic transformation. She did not undergo thrombolytic because she presented a little late, and also because her deficits were not much. And I believe she spent about 4 or 5 days in the hospital, and after that she was discharged with home physiotherapy. During the admission, she underwent routine workup that is typically done for a stroke patient. Her CT angiogram was done for intracranial, extracranial vessels, both of which were non-significant. There were age-related changes in rest of the cerebral parenchyma. Etiology for her stroke was thought to be cardioembolic. There was transthoracic and transesophageal echocardiogram, both done during the admission, both of which were reasonable for her age. So after she was deemed okay for discharge, she was discharged on dabigatran 150 milligrams twice daily. I'm guessing the thought process was that because 150 twice daily was shown to be superior to warfarin, as opposed to 110 milligrams twice daily, the idea here was probably to give her slightly higher dose of anticoagulation to prevent this stroke. Remember, she got this stroke while she was taking Rivaroxaban 20 milligrams daily. So she was discharged about a month back. Now she comes back for her 1-month follow-up, and that is where she's seeing me. So in my OPD, she comes in a wheelchair, but she's able to do her daily activities at home. So at home, she's able to maintain herself reasonably well. Her muscle strength is almost 5 on 5 now. She does not report any other symptoms, any other major symptoms, I must say. Her heart rate is in 80s, which is irregular, consistent with permanent atrial fibrillation that she has. And her blood pressure is around 110s over 50s. So now she's in my clinic. She's doing reasonably well. And I'm mostly thinking about secondary stroke prevention strategy in this patient. As you can imagine, she already has got one stroke, and she has very high CHA2DS2-VASc score, being female and in the age group. She definitely would need definite stroke prevention strategy. She will be seeing neurology. When she saw me, she would be seeing neurology as well. So the onus was on me also to provide a little bit of cardiology perspective of what anticoagulation I think I should put this patient on, or if there is non-pharmacologic stroke prevention strategy that I should be offering her. So I want to engage in discussion, particularly a little bit about stroke management in this kind of patient subset with atrial fibrillation, but also about stroke prevention, whether we should be choosing one NOAC over another if one NOAC fails, or should we be switching to old school warfarin or acetrom, that is your vitamin K antagonists. Is there any role of giving antiplatelets on the top of it, hoping that it will prevent further stroke, understanding that it does add bleeding risk? Or should we talk about non-pharmacologic stroke prevention strategy like LA appendage closure in this kind of patient subset? Or if there is anything else that we want to add when we talk about stroke prevention. I do want to highlight again that a TE was done in her case, and there was no any major abnormality, as in there was no residual thrombus in the appendage. Her intraatrial septum was intact, her LV function is intact, there is mild LA dilatation, but other than that, her heart seems to be structurally okay. So, Rukmini ma'am, this patient, if she is to come to you in your OPD to see, if you could just give me a little bit of highlight about typically what you end up doing with such inpatient when they get admitted to you, and how do you intend to follow them up over time? And please note that I have not mentioned all the other medication that she's on just for the sake of discussion, but she's on statins, she's on diabetes therapy, she's on hypertension therapy, all those things that she's on. But if there is any particular question you have, you can ask me that. Rukmini ma'am, the floor is yours.
Thank you, Dr. This is it's a difficult case. For us as a neurologist, if a patient comes with AF and the CHA2DS2 score is high, and you would put them on NOAC, and that has become the norm right now. Which NOAC we use is again dependent upon how the things came up into place. So most of the neurologists that I know use dabigatran because dabigatran was initially studied quite a bit in AF-induced stroke. And then there's the concept that the dabigatran compared to rivaroxaban and apixaban has got a lesser, just a little bit lesser side effect in terms of bleeding. This is our thought process. The other thing is that we normally give 150 milligram twice a day unless there's a renal compromise, when you would, like there is a mild renal, renal dosage reduction to 1. The question of changing, okay, the rivaroxaban actually, somehow most of us would have put them on dabigatran. The other reason why we put them on dabigatran is because you have an antidote which is available. These are if there's a patient who has got a bleeding. So a patient who's already on rivaroxaban and has come up with a AF which is actually has and thrown emboli, it's a little difficult call. If you ask me personally, I would think quite a bit, probably ask other people also and see whether we can look for other reasons, other ways of treating. But medical management, first thing that I would like to really rule out is if there's any associated atherosclerotic risk factor, because sometimes if you have an atherosclerosis and you're still not picking up the plaques and it's in the lower branch of the MCA, then I think you would, it would be good option to add on a low dose of antiplatelet in this patient. The second thing about whether to start the patient on acetrom versus, dabigatran compared to rivaroxaban, I don't think there are any studies which suggest that one is better than the other. Actually, compared to warfarin or acetrom, rivaroxaban and dabigatran has shown to be a little bit more efficacious, or at least not inferior compared to them. If you have real-world studies which have come up, a lot of studies have come up recently, suggesting that they are better in terms of the efficacy, or they're the same as in terms of the efficacy as warfarin, with a lesser chance of bleeding. The problem with using warfarin, acetrom, is all that you have to keep constantly monitoring the PTINR, and most patients tend to have a lot of fluctuations in their dosages. So in my opinion, I would look for whether there is another associated atherosclerotic risk problem. First, whether the patient was really compliant to rivaroxaban. Actually, that is the problem with NOACs, is if you drop the medication or you miss the medication, the chances of it causing a stroke is more. That is what I think. Like, even if you miss it for a couple of days. So first thing is whether the compliance is really good or not, and then continue with the anticoagulant and see whether we can add an antiplatelet. So those are my thoughts.
Ma'am, you mentioned about atherosclerotic risk factors or evidence of atherosclerosis. Now, I will tell you what all is done, and then you please guide us in terms of what all objectively we can do to establish the causality. Like, this patient has got diabetes. It is reasonably controlled. Her A1C was around 7.8 or so. So not perfectly controlled, but for her age, I can give it a pass. She does have hypertension. She is on statin for quite some time. Her cholesterols are in a reasonable level. She never had any coronary event. She never had a coronary angiogram done. Her ultrasound for her neck showed very minor plaque in her carotids. And her CT scan for her intra and extracranial vessels were more or less normal, without any major stenosis whatsoever. So this was the work that was done. To establish atherosclerosis, both in terms of disease or in terms of risk factor, is there anything else as a standard investigation or protocol that you do in these patients to decide whether they should be on antiplatelet or not?
If the CT angio is completely normal, unlikely that we would do something else. But if there is atherosclerotic process in the on the carotid Doppler, we can do a vessel wall imaging, or we can look at the plaque morphology using an ultrasound. So that would give us whether there is a lipid-rich plaque, if there is a plaque rupture. Vessel wall imaging can also pick up if there is any kind of inflammation which is there in the vessel wall. So maybe those can help, especially in a patient who is like this, who has developed a stroke in spite of having an AF. But given that, it is not that a NOAC is going to completely prevent, it reduces the risk. It doesn't bring it down to zero. So that's the caveat. But yeah, vessel wall imaging or ultrasound to start look at whether there is the plaque morphology in the vessel would probably help to some extent.
And is the vessel wall imaging different than the routine carotid Doppler that we do?
Yeah, you have to ask them to look for vessel wall imaging on MR is something which you can do in the intracranial vessel. The carotid Doppler itself, with an ultrasound probe, you can look at the carotid plaque. You can look at the plaque morphology.
And ma'am, any role of doing transcranial Doppler there? Can it help defining any atherosclerosis there?
No, transcranial Doppler again doesn't pick up atherosclerosis. It can pick up a stenosis. So that doesn't really pick up atherosclerosis. The thing is that you have a transcranial Doppler can pick up small microemboli. So you can use a transcranial Doppler to look at the emboli from the heart. Especially this is for patients who have got, patent foramen ovale. You can look at the hits on the, not in a patient who already, who has an AF, but like if you have a doubt, and if it's a stroke of uncertain etiology, you can do a transcranial Doppler and look at hits and see whether there are emboli coming up. That can help, but not atherosclerosis.
Not this. And ma'am, routinely when we do these investigations, our region of interest does not involve arch of aorta. Is it something that you routinely advise or do, or you think it doesn't add any diagnostic value?
No, it adds a huge diagnostic value. Actually, the point is that, yeah, we don't normally look at the arch of the aorta, but a TE is done to look at, that picks up the arch of the aorta to some extent. The arch of the aorta can have an atherosclerotic plaque, and you can have a embolism of the plaque. So an artery-to-artery embolism is quite common.
And
Again,
then
that
last
will
question.
respond to antiplatelets.
And then the last question that I have for you before I let you go, that is, so in patients who otherwise get admitted with stroke where we think the etiology is cardioembolic, but there is no atrial fibrillation, those patients are routinely placed on antiplatelet, regardless of whether there is any evidence of atherosclerosis or not. Is that correct, ma'am?
Yeah, that is correct. That is correct. But the point, there is a study. So when you, so suppose if you don't have any stenosis at all, it's called as ESUS, embolic stroke of uncertain, origin, or you're not sure whether the stroke is embolic or not. But you think that there is a chance of emboli, in the sense that you don't get any atherosclerotic areas, but you have these peripheral vessels which are with peripheral areas which have got strokes, or multiple territories which have strokes, and the vessels are still normal. Then, and you think that maybe there is a paroxysmal EF, or then, so in such cases, there's a trial which looked at dabigatran compared to antiplatelets to see whether that works better. It seemed to work better, but there's an increased risk of bleed. So most of the patients, if you have a strong suspicion of, a cardioembolic stroke, in the sense that if you have ejection fraction which is low, or if the patient, say that's where the transcranial Doppler high intensity transient signals can be picked up. It's called as hits. So those kind of things, if you can monitor, then you can say there is an emboli, then you can put them on anticoagulant. Otherwise, routinely, if a patient, you don't have any evidence of an emboli, you put them on antiplatelets only. True.
Ma'am, the reason why I asked you this question is that if we think that antiplatelets do have a role, then even in those patients who have atrial fibrillation but who have failed NOAC, as to speak, can we justify adding antiplatelet on the top of NOAC, understanding that it definitely will increase bleeding risk? What is your thought on that?
Very difficult call. This is a completely personal choice. It's got nothing to do with evidence. Evidence-wise, pathophysiology is important, but the point is, the evidence of using a combination is not very clear. But in the patient, if you in such a patient who's got diabetes, hypertension, who's old, a little older, I would still put the patient on antiplatelets, even though there may be an increased chance of bleed.
Thank you so much, ma'am. Sorry, go ahead.
No, there is no evidence. So it's not evidence-based. It's just a personal choice.
Correct. In fact, the kind of case that I'm discussing today, those are relatively uncommon scenarios, as to speak. The reason why I justify bringing this uncommon scenario in our routine discussion is because it pushes us to discuss few things which we otherwise routinely don't discuss. So maybe we can use these discussion points in treatment of some common cases that we have. So not necessarily the discussion won't apply to a similar case like this, which you will see in the future, but we can use the excerpts of this discussion and use it in our routine cases, as to speak. So that is the reason why I think when you mention, Rukmini ma'am, when you mention about lack of evidence, there probably is not going to be an evidence in these kind of scenarios to begin with, because they are so rare, so uncommon scenarios, that a systematic study in clinical cases like this is highly unlikely to happen. And most of these will be driven by consensus statement. Most of these will be driven by personal choices or personal biases, I must say. And most of these will be based upon extrapolation of the existing data that we have, which do not fit into these particular patients, but we can extrapolate it at our free will, knowing that there is no any obvious evidence into it. And that is what I'm trying to get people to discuss about it. So I will switch gears. I will ask Haigreve sir to give his comments. So Haigreve sir, let's say this patient were to follow up with you, and I'm talking from the electrophysiology standpoint. She has got permanent atrial fibrillation. Her rates are controlled. She does not have heart failure. She is, whatever medication she's taking, some beta blocker and some digoxin, seems like it is helping with her heart rate. The concern right now is stroke. And we are assuming that a person who has got atrial fibrillation, the stroke most likely is because of atrial fibrillation. There is really no way to prove it unless you see a clot hanging in the LA appendage. There is no way to prove it. So from the electrophysiology standpoint, anything you can think of in terms of our atrial fibrillation, and also share your thoughts about stroke prevention in this particular patient who already had one stroke on NOAC. Agreed, sir.
Hey, Anoop, thank you. Thank you very much for having me. And also, I appreciate this is a great case you've chosen, because I was personally first involved in a case like this in 2016 or so. And from then I have been having these kind of cases once in a while, and I've been constantly reviewing literature. And I was amazed to see how literature is changing year by year on this. First of all, actually, we think it is rare, but surprisingly, if you look at the literature, 22% of the patients with patients of AF on oral anticoagulation develop this kind of problems. So this is not a small number, and this 22.5% includes TIA and stroke, not stroke alone. And I'm talking about ischemic stroke only. Now, coming to the situation that you have, two aspects. One thing is chronologically timeline. We should see what we would have done in 2016-17 and what we are going to do in 2022, number one. Number two, the second aspect I would like to see is, in general, what will we do for patients like this? Number two, specifically your patient, which is more relevant to talk rather than in general, your patient, which you have described so much in detail, how we are going to manage. Few points I'm going to cover these two aspects. Before that, two questions. One, Dr. Rukmini has asked you to answer, which you have not, is whether the patient was compliant with the drugs. Number two, TE, I was keenly watching. You have mentioned everything, but did you see any aortic atherosclerotic plaques or grade 1, grade 2, grade 3? These two things I want from you.
So, sir, compliance, I do want to actually discuss about compliance. That is one of the questions which I will be putting up. To answer, to complete the question, she did mention that she is compliant with her medication, but I do want to come to this topic once I'm done with your thought process. That is one. And second, her TEE did not show anything in the arch of aorta. It did show grade 1 atherosclerosis in the descending aorta. But in the ascending aorta, the TE did not find anything significant.
Significant. Great. These two things are important when we are talking about the specific, when I come to the specific case. Now, first thing is, as I said, in 2017, the thought when I first had a patient like this, after discussing with different people across, outside the country and other things, what was described was what Dr. Rukmini had said. That is, the best drug to prevent ischemic stroke, the best NOAC is dabigatran 150 milligrams among the thing, because of the, if you look at the trials, it has shown superiority with a rider that, it increases more bleeding. Using VKA is not a option because it causes more bleeding and it doesn't cause any more protection from stroke than dabigatran 150 milligrams. So that part was thought about, and that's exactly what we did at that point in time when I first encountered a case like this. Now, switching gears now there is, over the period, data slowly come up. Surprisingly, first thing that has been described is that a large trial from Europe showed that by changing oral anticoagulation, it actually does not improve the risk of stroke. Surprisingly, this is what has been clearly told, and so is changing NOAC to warfarin. So that is a thing that is not going to greatly help, but then nevertheless, we need to choose the best, the most potent anti-ischemic agent right now for this patient. So using dabigatran 150 BD is a logical prescription, keeping in mind that it may not really help. Now, because this is a very crucial thing, this patient is 5/5 power, has no issues, sitting in front of you. We have a great responsibility to see that the patient has the least chance of developing another stroke. She's giving the medical community another opportunity to prevent stroke from her. So we need to explore all the possibilities. Now, coming to the 2022, what else are the other two things? Now, if you look at the causes of stroke in this patient, now, atherosclerosis, we are, your detailed investigation has excluded many of the things, but nevertheless, to enumerate, one of them is extensive atherosclerosis, one of the causes. Number two is an LA appendage persisting clot. you have excluded both of them. You have done a fairly detailed, whatever is available of atherosclerosis. And a third thing is artery segment to segment, intracranial dislodgement. I do not know whether by ruling out by MR, angio, or by intracranial Doppler, suppose you don't see any atherosclerosis, can we rule out a segment to segment embolus? I'm not sure, but you have done that, and that also does not show any clue to us that any of these have caused. And of course, the fourth cause is the compliance is a very important cause. Now, having studied all these things, so the options, the logical options in literature are only two for this patient. One is to add an antiplatelet agent to dabigatran 150 milligrams. And number two is to ensure compliance. And number three is to do an LA appendage closure occlusion, an LA occlusion device. So coming to the specific thing, quickly without wasting time, you have investigated thoroughly everything. So what appears to be is that AF is responsible for this patient's recurrent strokes, and the only thing we can do is to offer her an LA appendage closure and also add an antiplatelet, giving the risk of bleeding, which is a very important thing. So these are the only two things I would like, but we are going purely by a discussion point of view. There are issues of finances and social acceptance and all these things, but I think right now in 2022, this is the only logical approach to this patient.
So, sir, I will ask few questions to you again pertaining to electrophysiology particularly. So what if I generate a hypothesis where I say, let's get rid of atrial fibrillation altogether and reduce the risk of stroke? Is that possible?
Great question, because I'm glad you asked it, because this is one important misconception we all had, and that has gone away with the literature. That is, the reason why AF causes stroke is not AF itself, but it is a CHAT score. So if you had a AF with 0 CHAT score, these patients are as good as normal people. They don't cause stroke, so we don't even require anticoagulation, showing that getting rid of AF is not going to reduce the risk of stroke. And so is the case with AF ablation data also. All patients who undergo AF ablation, none of them have ever said that you can stop anticoagulation, even though you got cure of AF 2 years, 3 years, 4 years later. So as long as the CHAT score is high, anticoagulation needs to be given, risk of stroke exists.
Thank you so much, sir, for that exhaustive comment. I think I heard you correct, but I want to verify that one time, that one of the options that you mentioned is antiplatelet along with 150 milligrams twice daily of dabigatran in this patient. That is one of the option I heard, right?
Correct.
Correct. Okay, so I will move on. I will ask Shankar sir for his comments. Shankar sir, I hope you got the case. My question to you is very, very precise, and I would like your experience. Tell us how you deal with these scenarios. And my question is about drug compliance in those situations where you cannot monitor the drug efficacy. So when we give vitamin K antagonist, we can look for their INR level. We know whether the patient is taking, not taking, what is the dose, whether the dose is working or not. And then you have got drugs like NOAC, where you give the drug and you assume magically that the drug is working, which for most part it does, except in scenarios where patients don't take those drugs. And then secondly, the comfort level where we balance bleeding with thrombosis. So here we are talking about a 74-year-old female where we give them full dose, give her full dose novel oral anticoagulant. So dabigatran 150 milligrams twice daily arguably could be the most effective dose amongst all the oral drugs available. And then on the top of it, adding antiplatelet, which truly speaking may be a reasonable thing to do in her if we want to reduce her stroke burden, but at the cost of increased bleeding. So two questions I'm asking you, sir. How are we going to manage the compliance aspect of it? Or you think the old school warfarin is the best way to do? And second, what is your comfort level, or what you can tell us about this risk balancing strategy in elderly person, bleeding versus thrombosis, not just in atrial fibrillation, but maybe someday we may be talking about pulmonary embolism. Someday we may be talking about DVT or whatnot. This balancing act, Shankar sir.
Good evening to all. This is a very complex case. So far is nicely dealt by Dr. Rukmini and Dr. Agrawal. Apart from this compliance and the subtherapeutic doses of NOACs and this left atrial appendage thrombosis, aortic plaque, then LV thrombus also sometimes it gives rise to this thromboembolic risk and as well as a systemic embolism. So there, why I'm particularly mentioning this LV thrombus, in the literature, if you go through, the warfarin is superior to NOACs in this particularly left ventricular thrombus. So coming to the already talked about this left atrial appendage occlusion by Watchman device or other devices. That is an equally important measure to prevent the recurrence of atrial fibrillation, stroke. And second thing is, when we come to this argument regarding addition of antiplatelet agents, if you go through the literature regarding active W and active A trials, there it is proved that the dual antiplatelet agents are not at all effective, but at the same time, there is a higher rate of major bleeding. So even if single platelet alone, antiplatelet alone, as an aspirin or clopidogrel also, they did not prove any benefit in the recurrence of the stroke, because the oral anticoagulants, in spite of using the therapeutic dosage and the patient is compliant and adherent to the schedule what we have given, but Dr. Agrawal has already alluded to, there is a significant number of recurrent stroke incidents. So the only thing is I go with the LA occlusion, and second is this regarding the antiplatelet agents. I am not sure of it, because the so far trials have not given any evidence to prove that there won't be any recurrence. Then the aspirin or aspirin with the clopidogrel, they're not effective. Even aspirin with the low dose warfarin also trials were there. That is also not proved any benefit. And aspirin plus full dose warfarin also trials were there. There is no. And switching over to the warfarin is also not effective, because the NOACs, especially in the oral anticoagulation in this arena, ischemic strokes, the NOACs, they are superior to vitamin K antagonists. But amongst the all four available, dabigatran, Apixaban, the rivaroxaban, the edoxaban. But when I go through the literature regarding the Relay trial and the Rocket, Aristotle, there is no head-to-head trial. But if you go through those robust trials, I find the Apixaban is superior in this case, because robust evidence to show that the superior amongst all the NOACs. And the second thing is less major bleeding, especially the rivaroxaban. There is significant GI bleeding is there, but with the Apixaban, it is less bleeding is there. But here, if you give therapeutic dosage 5 milligrams twice daily, this is, I think, in my opinion, it may be superior to dabigatran. This is subject to correction. And then this is my opinion regarding one thing. Instead of dabigatran, can we add Apixaban or edoxaban? Edoxaban is not available in India, but Apixaban 5 milligram BID. Only thing is we have to give their dabigatran also has to be given twice daily. this also can be given twice daily. Apixaban, I substitute the dabigatran with the Apixaban, and this LAA, the left atrial appendage occlusion with the Watchman Craft with the percutaneous procedure. But I don't add any aspirin or a platelet antiplatelet agent, either clopidogrel or aspirin in this case, because all the trials, they showed there is a higher rate of bleeding with the addition of these antiplatelet agents. So I prefer to give Apixaban and the LAA closure. Thank you.
Thank you so much, sir. The forum is open for discussion. So if anybody has got any questions or comments, you can either raise your hand or unmute yourself, or put the question on the chat box and I will bring it up. And while you gather your thought, I will switch gears and I will come back to Rukmini ma'am for the questions which have been raised, but also the questions that I have. So Rukmini ma'am, what is pretty clear to me is that neurologists love dabigatran, probably because it was the early drug which came into the market. We all started using it, and there is definitely a good data set supporting its use. My question to you is, this dabigatran, and I believe the content has tartaric acid or something of that sort, if I remember correctly, which is hygroscopic in nature, and it kind of degrades the drug once it is exposed to the atmosphere. How do you deal with this particular limitation of the drug as compared to other NOACs in the Indian population, where the drugs are prescribed, where the drugs are dispensed in a blister pack? And it is very much possible that when a patient opens one tablet, he or she may inadvertently damage the other covering of that other tablet and make it exposed to the atmosphere. I hope I'm able to make my question clear. Rukmini ma'am.
Yeah, your question is absolutely clear. And first, I would like to really, say that Dr. Shankar and Dr. Agrawal really spoke so much about the NOACs. And I agree, with the fact that what Dr. Shankar has finally said, that in terms of the thromboembolic events, Apixaban seems to have not a significant, but it's still a little lower risk in terms of, it's a better protective agent in terms of thromboembolic events in general. But in terms of stroke, actually, strictly speaking, we have not found any difference there's not much difference between dabigatran, Apixaban, and Atherosclerosis. But again, as sir has said, that it is in terms of bleeding risk, Apixaban has the lowest bleeding risk, followed by dabigatran. Atherosclerosis has the highest bleeding risk. And obviously, warfarin and other anticoagulants have much higher bleeding risk. So, yeah, as you told very clearly, that because dabigatran was the initial drug to be used, and the fact that an antidote was available, the neurologist really did like to use dabigatran. It was also because dabigatran has been studied in a couple of other studies, like, as I told you, there was a study on ESUS where they did embolic stroke of unknown source. And that in those also, because dabigatran was the molecule which was used, people are using dabigatran. And I think Rivaroxaban and Apixaban was used more for DVD prophylaxis and peripheral thromboembolic events, as in the trials which were used. So that initially, so that's where I think that's the major divide. The moisture affecting the dabigatran is a problem, yes, but they're available in blisters. So the thing is that we tell them that it should not get wet. I have not done anything more specifically with my patients who are on dabigatran. I just tell them that moisture should not be there and it can spoil the medication. So be very careful when you're opening up one tablet. That's about how much is the information that I give them. I'm not sure if there's anything else I can do to help or tell them anything else which can prevent the degradation. So those are the two questions that you would ask, and that is how it is. So in this patient, I'm not sure. Giving antiplatelets is just a it's definitely an increased risk. And as Dr. Shankar said, it's completely personal. There is no clear-cut evidence to suggest that antiplatelets in this patient would help. As Dr. Agrawal has said, the anticoagulants do not really completely prevent the stroke, obviously. So it is like, there is a high chance of stroke even on NOAC. And I agree that probably closing the left atrial appendage would be a good option for this patient.
So, ma'am, the two other questions which I had for you, you have partly answered both of them, but I'm going to ask you just to get your thoughts completed. One is the LA appendage closure that you briefly mentioned. When you get, because strokes are primarily managed with neurologist at the front end of it, what makes you select a particular patient for non-pharmacologic stroke prevention versus continuing with a pharmacologic stroke prevention? Do you think these are the kind of patients where you think non-pharmacological measures will have better chance of improving outcomes, or you think they probably are similar to drugs that we are giving?
To be truthful, actually, most of the neurologists don't think of a non-pharmacological therapy initially, unless say you have a patient who's got something like a rheumatic heart disease or where there is or there has been so LA appendage closure is something probably very significantly underutilized by the neurologists in terms of the prevention. So in this case, where you have a stroke in spite of an anticoagulant, yes, that is when the thought probably falls into place. But before that, I don't think that we would think about it. So that is just because most of the neurologists are not taught about it, actually. LA appendage closure doesn't come into most of the discussions in terms of stroke management. That's a sad thing.
And then the last question that I have, which is more hypothetical, I don't have a good way of asking this question. I know it's very, very arbitrary question, but I'm going to ask you. If this patient was to have a second intracranial event, yes, from a neurological standpoint, which will be a better event to manage? Will it be a second thrombotic event, or will it be a hemorrhagic event? Now we are talking about a balancing act of thrombosis versus hemorrhage. If this patient had to get another event, which one would you pray for to say that, okay, this patient should not have one hemorrhagic event or one thrombotic event? Which one you think is more likely to cause damage to her?
Both of them will cause damage to her, but the thing is that stroke, the thrombotic event or I think for me personally, it would be easier to deal with a thrombotic event compared to a hemorrhagic event. The hemorrhagic event always makes a mess of the whole medication regimen. So you have to stop the medicines, probably put them on low molecular heparin. You don't know whether you can continue it or not. It depends upon the size of the bleed. So many issues come in. And then you have to, because the patient is on dabigatran, probably you can give an antidote if it's early enough in time. So it's much more, it is in a way, maybe you can manage it, but it is much more complicated on a long-term follow-up because you never know when the patient will develop a bleed again. Once a patient develops a bleed with an anticoagulant and the indication still persists, you have to restart the patient on the anticoagulant. But again, you always do it with a fear that you're going to precipitate another bleed. So for me, I think a thrombotic event would be easier in terms of treatment on a long-term basis. But as far as the patient is concerned, both a thrombotic event and a hemorrhagic event are equally bad.
Thank you so much, ma'am, for answering those questions. And again, I'm trying to, some of the questions that I'm putting up are sounding a little rhetoric, but I'm trying to again initiate the discussion so that when we are making decision with our patients, clinical scenarios, at least we can put some of these thoughts in our mind before we make a discrete decision for any particular given patient. If any one of you have got any questions or comments, please feel free to unmute yourself or put a question in the chat box. At this time, I will ask Somaraju sir for his opinion for cases like these in terms of what should be a better strategy to manage such patient. Somaraju sir.
Thank you, Anoop, and thank you, everybody. It's a very nice example you brought up, and a very nice discussion, and everybody gave their point of view, and it was a learning experience. But having said that, I just wanted you to, if you recollect, you said, correct me if I'm wrong, the blood pressure is 110/50. Can you elaborate it?
Yes, sir. This was the blood pressure which she was on at the time when she came to follow
No.
up with me. Yeah, 110/55 was her blood pressure in my OPD.
Okay, now you ask, we request our specialist to interpret this finding in this patient and the significance of this blood pressure in this patient. Then I will say something more. Thank you.
Sure, let me bring up this discussion. So, Rukmini ma'am, I'm going to ask your opinion on this. I know that neurologists get very particular when we are dealing with hemorrhagic stroke to maintain a certain blood pressure so that you have got enough cerebral perfusion pressure to go into. And sometimes we even put intracerebral pressure monitoring or intracranial pressure monitoring to make sure that the CPP, as to call it, it is adequately maintained. How about in ischemic stroke, as what Somaraju sir is pointing out? Is there a certain blood pressure that you want?
Actually, the other way is true. I mean, the hemorrhagic stroke, people have looked at the concept was that both the ischemic stroke and the hemorrhagic stroke, there is a penumbra, ischemic penumbra. So initially it was thought that it would be there even with hemorrhagic stroke, but definitely with an ischemic stroke, you have an ischemic penumbra. So in ischemic stroke, at least in the first week after the stroke, we would like the BP to be on the higher side. The mean arterial pressure to be around 120. So actually the dictate for managing hypertension in patients with ischemic stroke in the initial 1 week is that we don't treat unless it's around more than systolic is around more than 180 or the diastolic is more than 105. Even if we give a thrombolytic agent, this is with a intravenous thrombolysis. If you're not giving intravenous thrombolysis, even 220 over 110 is the you don't need to intervene till you have such kind of blood pressures. So normally we don't reduce the blood pressures remarkably in the first 3 days after the ischemic stroke, and first 1 week also we keep the mean arterial pressure around 120. So that is with ischemic stroke. The hemorrhagic stroke, people thought there was an ischemic penumbra, but that has not been proven to be the case. So if you have an ICH, the idea is that you can reduce the blood pressure. There have been trials where they have reduced it quite significantly, and they brought it down to a systolic of 110, and within the first 24 hours, and it didn't show any significant worsening. But with an ischemic stroke, if there's always a chance that the stroke can increase in size. So as Sir said, Dr. Somaraju Sir said that in an ischemic stroke, we would like to have a higher blood pressure. How high is again is a big of a question. So if the patient is already on stable antihypertensive, so this is how we treat. We don't give them, if the blood pressure drops below 100 systolic, we do put them on inotropic agents. But if the patient is already on a stable antihypertensive dosage before the ischemic stroke occurs, we continue with the antihypertensive doses. We don't stop it at that point. So because most of the patients will come with a cardiac and neurological problem, and if the blood pressure just goes up, they may land up in cardiac failure, which is also not good enough for the brain. So again, there's a lot of gray zone in this territory, but we like the blood pressure to be on the higher side.
And you said that is there in the first few weeks. You would say that strategy?
1 week, first 1 week. After 1 week, we reduce the blood pressure down. Immediately after stroke, 24 hours. So that's how. Sorry.
Right. Somaraju sir, any question? Yeah.
What I heard, correct me, if I read it wrong. I'll say, with what other findings, whatever you described, I would say the significant contribution to cerebral ischemia or TIA or infarct in this patient is significantly contributed to by this lower blood. It's called diastolic hypotension. In a 72-year-old person with a blood pressure diastolic of 55, systolic is not high, is a serious risk factor. You talked about transcranial Doppler. Transcranial Doppler allows you to measure cerebral perfusion. And in this patient, if it was done, it would be low. I also want to know what was the heart rate around what heart rate this patient was maintaining and what drugs this patient was on when this blood pressure was recorded. To me, I would say the whole is larger than the sum of its parts. This low diastolic pressure was a serious issue. To me, it's more important and more serious risk in this patient than atrial fibrillation. Thank you.
Thank you so much, sir, for that insight. This patient, while I was not actively looking at the blood pressure aspect of it, I must admit, this patient was on beta blocker primarily for her rate control for atrial fibrillation. And that beta blocker was treating her quote unquote blood pressure as well. If I recollect, I think she was getting 50 milligrams of metoprolol as a 24-hour dose. Other than that, she was not on any other antihypertensive. And of course, she was taking digoxin 5 out of 7 days for a rate control. Her heart rate when she came to my OPD was maintained in around 80s. And during her inpatient stay also, she never had tachycardia episode. Her heart rate would fluctuate somewhere between 60s, 70s to 100 teens. But like I was never bothered about her tachycardia when she was admitted in the hospital. But truly speaking, I did not actively seek to reduce her beta blocker in an attempt to increase blood pressure. It does make sense that when you have a lower diastolic pressure, then maybe the perfusion to end organs, particularly brain, can get compromised. Rukmini ma'am, you have any thoughts on this?
Yeah, so before answering this, like in patients with like when you have a stroke, you can actually pick up whether the patient has got border zone infarct. So in the scan, so if they have a border zone infarct, or whether if there's an external or internal border zone infarct, that would suggest that the patient has got a low perfusion pressure in the cerebrum. So in such cases, you can think about whether you need to change the antihypertensive. So if it's only an inferior division of the MCA, if it's if the cortex is also involved, significant cortical involvement, then I would think that the perfusion pressure is not the reason for causing, the drop in the blood pressure is not the reason for causing the stroke. But if there is a border zone infarct, so you can have border zone infarcts are usually seen just, either at the territory between the MCA and the AC, or the MCA and the PCA, or you can have an internal border zone infarct within the same territory, the superficial branches and the deep branches of the MCA. So there are specific areas of the brain. So it is in the centrum semiovale, which you see a lot of infarcts. So you can see it looks like multiple lacunar infarcts in the middle. So if you have such kind of an infarct, then definitely you have to think about the blood pressure as a cause of it. So in which case you can reduce. If it is not, then we won't.
Thank you so much, ma'am. I'm looking for any questions or comments that anybody may have. Dr. Vamsi Krishna writes that atherosclerosis may be there in view of low diastolic pressure. Dr. Vamsi Krishna, that point is absolutely well taken. And at her age, I would expect she to have a little bit of atherosclerosis. It's just that whether our imaging strategies are able to pick it up or not. Shankar sir, you have anything to add? And Hygri sir after that?
This patient is long-standing persistent AF or permanent AF. She is on digoxin. So elderly lady with a digoxin without heart failure, is it worth continuing digoxin in this case because of side effects associated with the digitalis?
See,
Hygri sir,
I'll take this question.
That question, and you can also your comment. Hygri sir.
Yeah, I'll take this question. See, it's like this. See, if you have you're absolutely right. If you have a heart failure and a atrial fibrillation, hypotension, and fast ventricular rate, the best drug is digoxin. But you see, this patient has permanent atrial fibrillation. The way to treat permanent atrial fibrillation with a normal LV function is you start off with beta blockers and calcium channel blockers. But many times what actually practically happens, as is happened, as you can see with the blood pressure, the whole talk of blood pressure, if you have a systolic blood pressure of 100, I'm sure you cannot uptitrate any more calcium channel blockers or beta blockers. You are left with no choice but to add another rate control drug like a digoxin. And for the sake of information, in case that also fails and then you have digitoxicity and other problems, you have no other option but to do some AV nodal ablation and get some and put a pacemaker and get some rate control. This is the standard way of treating rate control protocol wise. My one thing is actually I have to ask a question, totally deviate, because it's so important and interesting. The discussion on hypertension, which Dr. Somaraju sir has brought up, is really amazing insight into this. And also the clinical insight Dr. Rukmini provided, that how to, how we would clinically suspect a hypertension to be cause of infarct rather than something else. Sir, Somaraju sir, I want to ask you is, totally, unconnected with this case. See, this diastolic hypotension, that is patients having diastolic of 50 to 60, is so common actually when these days everybody is measuring blood pressure and coming to us. How much importance in clinical practice do you give to isolated diastolic hypotension, and what do you do about
it? I agree. This is generally neglected area, but there are clinical experience and then there are reports. After age 55 or so, the diastolic pressure goes on coming down in a significant number of people. And but along with it, as a compensation, systolic pressure rises, so that mean arterial pressure is still maintained. But when any of them sees us, if they don't see a doctor, they are lucky. They see a doctor, we aggressively try to treat the systolic pressure, and then they start having problems of a variety of nature, and including, say, low perfusion pressure related areas. Imagine somebody above 70s have significant vascular disease, whether in the brain, kidney, or heart, and you may precipitate a variety of areas of ischemia and problems, and then this area is often generally under-recognized and mismanaged. So that is the reason why it's very important to check blood pressures in these patients carefully. Actually, most of us were trained as medical students to later. So when the moment you reach 80, you take off your stethoscope. You don't even record diastolic pressure carefully. And also there are issues related to measurement of blood pressure in atrial fibrillation also. Most of you would be also aware. But be aware, diastolic hypotension is a significant issue. It is a diastolic pressure which drives pressure flows across the whole arterial system. And particularly in elderly people, you have to be careful. You go out of the way to try to correct it. And I'll leave it here. Thank you.
Thank you, sir. Thank you so much.
Somaraju sir, I have a follow-up question on that. Do you think we are heading towards, or we should be thinking about aiming for a mean arterial pressure in elderly population rather than simply looking at systolic and diastolic? Now, since you mentioned that typically their maps are well maintained.
Yeah, I agree with you, and even the literature is very inadequate on this, and you have to individualize. Go by the patient symptom, go by mean arterial pressure, and don't overtreat systolic hypertension when the diastolic pressures are less than 70. In elderly people, don't be aggressive in trying to reduce blood pressures. That's extremely important. That's what I can say. Thank you.
Thank you so much, sir. If there are no more points to be discussed, I will invite Praneeth if he is available. Praneeth, can you give your closing comments about today's discussion?
Yes, Anoop. So it was a difficult case, as you said. It's a difficult situation to manage a patient who has a stroke on anticoagulants. So the various causes, the possibility of atherosclerosis, and the possibility of embolism has been well documented, and Dr. Haigiru clearly mentioned that there is no documented evidence of changing one NOAC to other, but we still do. And it's okay to do it because individual preference is there, though there is no data backup. Because of the evidence, probably dabigatran seems to be the preferred anticoagulant of choice or preferred drug, but we need to be mindful about its hygroscopic nature, which is what probably patients have to be explained. And the importance of hypertension, particularly in the days where there is a push of lowering the blood pressure more and more to lower numbers thanks to the sprint data. But the importance of hypotension, particularly the diastolic hypotension contributing to ischemic events, is again well highlighted. So I think we should be equally be mindful that lower is not always better. Probably we need to find a sweet spot where the ischemic events or other complications can be prevented. So I think a very thought-provoking discussion. And I think if a multidisciplinary, we can put the patient in the center, and if we can look at all the options, probably the extra pharmacological options like LA appendage closure also probably should be considered. If not for everybody, but for selective patients, it might make a difference. And I think the interaction between neurologist and cardiologist should make this idea or the thought come more frequently for a deserving patient. So I think a very good discussion that we had today. Thank you.
Thank you, Praneeth. Thank you, Haigiru sir and Rukmini ma'am, for your insightful thoughts on today's topic. There is one question that came. I'll just take that question, and then after that we can close. If we plan for LA closure, what things to give on follow-up? Should we continue dabigatran? So, Dr. Vamsi Krishna, I can quickly answer that question, and then we can close. The whole idea of doing LA appendage closure is to stop anticoagulant, and then we can simply just put these patients on antiplatelet. So if you intend to continue a patient on oral anticoagulant, then probably it doesn't make sense to do LA appendage closure. This is what the guidelines would suggest, and this is what would be the scientific way of doing it. I remember me and Haigiru sir discussing this a few days back, that why do we need to restrict ourselves to strict hardcore guidelines, which, I mean, they are there for a purpose. I don't want to negate that. But the idea here is, if we are uncomfortable pushing the dose of anticoagulant beyond a certain level because we are concerned about bleed, but at the same time, patients who do have stroke while on getting conventional dosing, we cannot accept the risk of stroke further as well. In those patients, can we have a middle ground where we put a device therapy like an LA appendage closure and continue on the same old dose of oral anticoagulant or whatever anticoagulant without increasing the dose? So that way we are not increasing the risk of bleeding, and at the same time, we are probably adding more protection to stroke prevention by giving LA appendage closure. So that was the discussion we were having. Of course, there is no data set for it, and the scientific literature would not support this hypothesis, because this has not been tested so far yet. But I remember we had this discussion, there was no clear outcome of it. So as of right now, if we intend to do LA appendage closure, the intention should be to stop oral anticoagulant, and that should be the reason. Now be mindful that when you do LA appendage closure, in about 5 to 10% of the cases, probably around 5 to 7% of the cases, they will have residual leak around the device, and presence of a residual leak at a TEE done at 40 days would tell you to continue oral anticoagulant for rest of the life. That would be considered as a device failure. So that also you need to keep in mind, that every patient whom you do LA appendage closure, not all of them you'll be able to stop oral anticoagulant. In about 5-7% of them, they will have some leak, and you may need to continue drug for lifelong. So I hope that answered the question. And with this, I would like to close. It's 9:10. So thank you all for being around with us this late in the evening. We will see you again next Wednesday. As you know, we have been doing this every Wednesday over the past 2.5 years now. And next Wednesday, we'll come up with a new topic. Till that time, I wish you a good rest of the week. And again, thank you for my guests for today's discussion. Good night, guys.
Good night. Thank you, Anoop.
Thank you. Good night.